Today, we are on site at McCormick Place in Chicago at the 2019 ASCO Annual Meeting. We'll be recapping some of the top news presented each day during the meeting, and soon we'll speak with Dr. Manish Shah on the latest results in gastrointestinal cancers and Dr. Scott Tagawa on the most exciting studies in prostate cancer. Welcome to OncLive News Network. I'm Gina Columbus. In prostate cancer, nearly 80% of patients with metastatic hormone-sensitive prostate cancer who were treated with enzalutamide plus standard of care were alive after 3 years, compared with 72% of patients who received a different non-steroidal anti-androgen plus standard therapy, according to results from an interim analysis of the Phase 3 ENZAMIT trial. Results showed that the 3-year overall survival rate for men who received enzalutamide was 79% versus 72% in those who received another NSAA. In the Phase 3 POLO trial, maintenance therapy with olaparib significantly improved progression-free survival compared with placebo among patients with germline BRCA-mutated metastatic pancreatic cancer. The median PFS with the PARP inhibitor was 7.4 months compared with 3.8 months with placebo. In multiple myeloma, higher incomes and having private insurance were associated with significantly greater probability of survival for patients with multiple myeloma. At a median 30 months of treatment, patients on study who were living in areas with a median regional annual income of at least $46,000 had a 16% greater chance of survival compared with those living in less wealthy areas. Moreover, those with private insurance had a 59% greater probability of survival versus those insured through Medicaid, and a 62% greater probability of survival than the uninsured. Private insurance was also associated with longer survival for those aged 65 and older. A subcutaneous formulation of daratumumab is non-inferior in efficacy and pharmacokinetics compared with standard intravenous daratumumab in patients with relapsed refractory multiple myeloma, according to data from the Phase 3 Columbus study. Results showed that the rate of very good partial response or better was 19% with the subcutaneous formulation compared with 17% for the IV formulation. The subcutaneous formulation had a much shorter administration time of 5 minutes compared with over 3 hours for patients receiving the IV treatment. Additionally, no new safety signals emerged with the subcutaneous formulation. For a full review of all of these studies, please visit OncLive.com. Here now to expand on a handful of gastrointestinal cancer abstracts is Dr. Manish Shah, Chief of Solid Tumor Oncology and Associate Professor of Medicine at Weill Cornell Medicine, New York Presbyterian Hospital. Hi, Dr. Shah. We're so happy to have you here today. Thanks for being here.
So happy to be here. Thank you.
So, the POLO trial is one of the most talked about abstracts in pancreatic cancer at this year's meeting.
Yeah.
So, what can you tell us about it so far?
Yeah. So, this in many ways is a practice-changing study. So, the POLO trial was a study specific in pancreas cancer in patients who have the BRCA1 or 2 mutation. And that occurs in about 5 to 10% of pancreatic cancer patients. And we know that these patients, they have a defect in DNA repair, and they likely do benefit from a PARP inhibitor. And the POLO trial is the olaparib PARP inhibitor. And this was a randomized study in patients who received FOLFIRINOX. And if they didn't have disease progression, they had stable disease or response, they were randomized to best supportive care or olaparib. And there was a significant improvement in patient outcomes with the olaparib arm. So that was in fact a positive study. So it does a couple things. It improves, it provides a proof of concept that targeting BRCA in pancreatic cancer is important and effective. So I think that's a critical thing. Based on that study and other studies, now ASCO guidelines and NCCN guidelines have recommended that anyone with pancreatic cancer should get genetic testing for BRCA as well. So those are two key features of the study.
Good. Those are some great points. Thank you. Now, can you tell us a couple of things about the GO2 trial that's evaluating elderly and frail patients with advanced gastroesophageal cancer?
Sure. The GO2 trial is a very important study. A lot of patients that we see are elderly and frail, and they may not meet criteria for standard treatments. You would not give someone who's older and frail, has comorbid conditions, FOLFIRINOX, for example. So this was a study that looked at chemotherapy reduction and less intensive therapy, and it did show that there was an advantage with reduced toxicity without compromising efficacy. So that was a key aspect of the study. The GEO-2 trial, actually though, uniquely, it changed to a superiority study sort of midway through. So that was something that the discussant brought up this morning, which was of interest.
Okay. Now, we also saw data from the phase 3 KEYNOTE-062 trial with pembrolizumab with or without chemotherapy versus chemotherapy for advanced gastric or gastroesophageal junction adenocarcinoma. So can you speak to these data and why it's important?
Sure. So immunotherapy in GI cancers is still evolving, and the KEYNOTE-062 trial is a first-line study of 3 arms. There was a standard chemotherapy arm of FOLFOX. There was FOLFOX plus Keytruda and Keytruda pembrolizumab alone. It was limited to PD-L1 positive patients, which is about 50 to 60% of gastric cancer. And there were a couple different questions that were asked. Does immunotherapy plus chemotherapy improve survival, both progression-free and overall survival versus chemotherapy alone? And also, does Keytruda as monotherapy, is it equivalent or at least non-inferior to chemotherapy either in progression-free or overall survival? And the study was complicated as it is. It did achieve at least one positive result. So the Keytruda monotherapy arm was non-inferior to chemotherapy in the PD-L1 positive group. So that's very important. Some key things to think about in this study, though, is that when we're doing a non-inferiority study, we look at how much worse could the experimental arm be and still be considered equivalent. And the hazard ratio for that was 1.2, which is acceptable, but what it means is that up to, your patients could be doing up to 20% worse with Keytruda versus chemotherapy, and I think individual physicians and patients would need to think, is that something that's meaningful to them?
Good, great points. Now, another trial looked at survival outcomes with laparoscopic versus open resection for patients with gastric cancer who have liver metastases. So can you tell us a little bit about that?
Yeah, so this was a study of laparoscopic versus open resection for patients with gastric cancer. And this is an important study because although there are previous studies that suggested that laparoscopic resection can be done, it's technically challenging because the stomach is in the upper part of the body, and there's lots of things that need to happen to take out the stomach safely. This was not with liver metastases, but it did show in a very large randomized study that there is no detriment in outcome with laparoscopic surgery. So I think if you're well trained, if you have experience in laparoscopic technique, then you're perfectly reasonable to do a laparoscopic technique and offer that benefit to patients.
Good. So what are some other GI cancer studies that are being presented this year that you're really excited about?
Yeah, so the GI field has really evolved quite a bit. We see actually a very exciting study in cholangiocarcinoma. This was the follow-up to the gemcitabine cisplatin study, which demonstrated benefit in the first-line setting. There remains a question what to do after patients progress on gemcitabine and cisplatin. So there was a large study comparing FOLFOX versus best supportive care or active supportive care. And what we found out is that FOLFOX does have activity. Patients had a better outcome, progression-free survival and overall survival, and I think that's the new standard.
So let's take a look at now all these data that we have that's been presented at this year's meeting. What do you think that tells us about the future of the GI cancer paradigm overall?
Yeah, so in the last several years, thousands and thousands of patients have been put on clinical trials in GI cancers, both colon cancer and upper GI cancers. We talked mostly about upper GI cancers here, and it's really exciting that we are making advancements. I think that we feel like there's more to do, obviously, but we do see incremental benefits with the trials that we're doing. So we really thank all the patients and all the participants in the trials.
Great. Well, Dr. Shah, thank you so much for coming by today. Really
Absolutely.
happy to hear your insight.
Great. Thanks for having me.
Great. Thanks. Next, we are here with Dr. Scott Tagawa, who's from the Division of Hematology and Medical Oncology at Weill Cornell Medicine and New York Presbyterian Hospital to discuss the latest findings in prostate cancer at the 2019 ASCO Annual Meeting. Hi, Dr. Tagawa, how are you today?
Hi, doing great. Pleasure to be here.
Thank you so much for being here. So there's a lot going on this year at ASCO in prostate cancer. So this year we learned of overall survival data from the phase 3 ENZAMIT trial in metastatic hormone-sensitive prostate cancer. So can you speak to the significance of these data?
Sure. I mean, quite simply, it's great to have another drug that improves overall survival in this very important patient population that walks in the door with metastatic disease. And similar to other drugs before it, and as another drug that we'll talk about, drugs that work, to some extent in a later stage of disease work even better in an earlier stage of disease. So it's just great to have different choices for our patients.
Now, what about apalutamide with the Titan trial?
So very similarly, similar mechanism of action as enzalutamide, similar but not exactly the same population, also allowing docetaxel, although the percent that received docetaxel, actually sequentially for apalutamide, was lower. But overall, again, another drug that hopefully is going to be available for our patients.
Great. Now, what are your thoughts on the darolutamide health-related quality of life data that we've seen in prostate cancer, and what's really the excitement that surrounds this agent?
So, is a general statement in this M0 castration-resistant population, so not a lot of metastatic disease, presumably not that symptomatic, although there could be fatigue. It's great that we have drugs that work in that space to delay an important event, development of metastatic disease, without a deterioration of quality of life. That's my overall summary of the darolutamide data, as well as the apalutamide and enzalutamide data that came last year. The interesting part about darolutamide in a different patient population, different trials, is that it looked like some of the AE rates were lower. Again, it's cross-trial comparison, so there's caveats with that, but that's very interesting to the field. And there are some planned head-to-head phase 2 type studies that will look to address some of the different toxicity and patient-reported outcomes with the different drugs.
Great. Now, what are some other prostate cancer studies being presented this year that you're really excited about?
Additional studies that were presented yesterday and the day before were of interest were additional data with olaparib. So building on TOPARP A, TOPARP B, really, not a randomized trial, but really validated some of the results we saw in TOPARP A, as well as with at least one other PARP inhibitor, that in a molecularly selected population, there is a good chance of response, and those patients look like they do better than historical controls, in particular because without those types of drugs, it looks like some of those genomic alterations, such as BRCA2, are a worse prognosis without those drugs.
Now, beyond prostate cancer, what are some other abstracts in either bladder cancer or kidney cancer that you'd also like to highlight?
One of the major ones I'm looking forward to are the updated data, phase 2 data with enfortumab vedotin, which is an antibody drug conjugate against Nectin-4. And we've seen some data from their phase 1 trial and expanded phase 1. This will be really their phase 2 data. And from what we've seen, it looked like it's going to hold up, and that could lead to accelerated approval even while the phase 3 trial is going on. So it's great that we've made advances in advanced urothelial carcinoma since cisplatin with immune checkpoint inhibitors that work very well, but just in a subset.
Right.
Erdafitinib was just approved in a subset, but very important for that disease subset. And hopefully we'll have at least one, if not multiple, antibody drug conjugates down the line.
So if you had a crystal ball in front of you and you were looking at the field of prostate cancer 5 years from now, what does it look like to you?
So what we've done over the last 5 years is come up with new drugs that importantly have led to advances in survival as well as patient-reported outcomes in different disease settings and have moved existing drugs forward. At the same time, we've been working on biomarkers to select out patients who are more likely or less likely to benefit from these drugs. And I think it's going to be more of the same in a way, but with additional drugs and new targets. So I think there'll be new drugs that are out there that will work in tumors that may have resistance to the existing drugs. We'll move those drugs earlier, and hopefully with a patient sitting in front of me with drug A and drug B as choices, I will be able to pick which one I think will be better for that individual based on clinical and genomic and other biomarker factors.
Well, Dr. Tagawa, thank you so much for sharing your insight today on all that is happening in prostate cancer here at ASCO. I really appreciate it.
No problem, it's a pleasure.
That's all for today. Stay tuned for tomorrow's OncLive News Network On Location, where we will sit down with Dr. Elizabeth Klimak on genitourinary cancer studies and Dr. Leora Horn of Vanderbilt University on exciting lung cancer trials. And don't forget, the OncLive Global Expo is taking place October 11th through 13th in Orlando, Florida. Join us for a fully interactive meeting that brings together the most inclusive group of oncology professionals to collaborate on emerging trends and technologies in oncology care and research. Thank you for watching OncLive News Network. I'm Gina Columbus.